Hello all, and welcome to the Psychosocial Abstract poster presentation as part of NACFC 2020. Thanks so much to the Cystic Fibrosis Foundation for doing such a great job transitioning this meeting to online. My name is Rebecca Hayes. I'm a mental health coordinator at University of Wisconsin Adult Cystic Fibrosis Program, and I am moderating the session with Lara Dinga. Who will be doing the hard work of coordinating your questions in the background. The abstract session this year was particularly difficult given the tightened format of this meeting. And so I'm so excited to learn more from the three abstracts that we'll learn about today. First up is Lisa Opipari, who is a faculty member in behavioral medicine and clinical psychology and at the Anderson Center for Health Systems Excellence at Cincinnati Children's Hospital and the University of Cincinnati School of Medicine. And she's going to be sharing a bit about a digital nutrition plus behavior intervention that shows feasibility, acceptability, and preliminary effectiveness when used in clinical care of pediatric patients with CF. Before she gives her talk, I have a couple of housekeeping notes. The first is that to the right on your screen, you'll see two different options for offering feedback. One is chat. That's to say hi to your friends that you notice are weighing in on the session. And then there's Q&A, and that's where to direct questions to our esteemed speakers. And each abstract will give about a 10-minute presentation with 5 minutes for questions, and then we'll move on to the second and third abstract. Thanks so much. Take it away, Lisa.
Okay. All right. Hi, everyone. Can you all see my screen? I'm assuming I'm not hearing anything, but I'm going to go ahead and get started and assume someone will let me know if you can't. So the study was funded by a grant from the CF Foundation. Let's see here. Actually, okay. There we go. I'm assuming people can see my screen now. Yes, awesome. Okay, so this study was funded by a grant from the CF Foundation Success with Therapies Research Consortium. There are no other disclosures other than that. So it takes a village to do this kind of work, and many thanks to our collaborators, including our coordinating center at Boston Children's Hospital, our data management center at Johns Hopkins, and our clinical sites who work so closely with us to do this work. Be in Charge is an efficacious behavior plus nutrition intervention for improving calorie intake and weight gain in children with CF. There has been over 2 decades of research on this intervention that has demonstrated that it works. It's included in clinical guidelines for both preschool and school-age children with CF. So given the strong efficacy data, we have been working with the CF Foundation to translate this research-based intervention into clinical care and to evaluate its effectiveness. And that's what I will be talking about today. In thinking about how to translate Be in Charge into care with an eventual goal towards implementing this at scale across CF clinics, we recognized we couldn't do that without a digital format. So as a first step, we partnered with parents of children with CF, CF clinicians, and technology experts, and we worked to identify the end user needs and goals for both of our families and our care teams in terms of technology, functionality, look and feel, accessibility, as well as clinical workflow and technical requirements. We spent about 24 months doing this in an iterative design, build, testing process and working with these groups. And at the end of that phase, we moved into a pilot implementation study in clinical care. And that's the results that I will be sharing with you today. So just a little bit about the Be in Charge technology platform. We translated BIC, as we call it for short, into this digital platform that was used by families and their clinicians. Typically, clinicians using it were dietitians and psychologists. For families, we created a web-based program that they accessed via mobile app or computer, and that included psychoeducational content, a diet tracker with progressive calorie intake goals, and real-time feedback on the calorie intake. For clinicians, we created a dashboard that lived on the CF Care Center portal, so it was easily accessible to the clinicians. They didn't need new logins, new passwords. They already had all of that and were already using that portal. And it allowed them to see their patients' progress through the program and calorie intake in real time. And the two sides of the platform talk to each other. Okay, so our objectives were to evaluate Big Digital on change in weight, daily calories and estimated energy requirement when integrated into care, and to assess feasibility, acceptability, and satisfaction. We conducted a non-randomized pre-post trial across 7 pediatric CF care centers. We were interested in effectiveness when implemented in the context of care. So we used a pragmatic design with minimal exclusion criteria, and as much as possible had this implemented by care team members as opposed to research coordinators, so we could mimic as closely as possible use in clinical care. This schematic shows sort of the basic process for studies for families who were enrolled in the study. So a family would enroll at a regular clinic visit. They would then go home and independently use the BIC digital application. And this included completing 7 psychoeducation sessions, tracking their diet daily on an app, and doing skills practice with everything they learned. It typically took families about 7 to 14 weeks to complete the program. Simultaneously, our care teams would review their patients who were using the platform weekly. They would offer personalized support as appropriate or if needed by the family. And throughout the program, we had quality improvement experts who integrated in to this work to work to create and optimize implementation strategies to really help clinics learn and families learn to optimize the results. So very briefly, in terms of our study population, our study was shortened due to COVID, but we had 73 confirmed families who were eligible to participate. Most of the families chose to enroll, and over half of those who enrolled completed the full study. Our withdrawal rate did seem to be affected by COVID, as about almost a quarter of our patients who withdrew or were lost to follow up did so around the time of sort of March or April, had enrolled and were working on the program when sort of COVID and quarantine and the pandemics hit. In terms of demographics, children in the study were between 3 and 10 years of age. Mean age was 6, about half were female. Mean BMI percentile was 36, and most of our kids were pancreatic insufficient. So what did we find? For participants in this study, there was significant improvement in weight, calorie intake, and percent EER. Our kids showed an average 1.2 kilogram weight gain. The average time to complete the study was about 12 weeks. We saw an increase of 246 calories per day on average, and an increase percent EER, the estimated energy requirement, increased by 12.5 percentage points for an average end of program EER of 127.4. BIC Digital was feasible to introduce and engage families at clinic. We saw that 88% of families who were eligible chose to enroll at their clinic visit, and it was possible for physicians and dietitians to introduce this and talk about it within the context of the clinic visit in terms of time. Physicians spent in 83% of the visits, physicians spent 5 minutes or less introducing this. For dietitians, in 74% of their visits with patients, they spent 10 minutes or less. So very doable in the context of care. It was acceptable to both our clinicians and our parents. Our care teams reviewed patient data at least weekly, on average 75% of the time, or 75% of the weeks that they had patients enrolled. And 60% of our families who registered for the program actually went home and completed it. Most clinicians and parents were satisfied or very satisfied with the program. 88% of our parents reported they were satisfied or very satisfied. For physicians and dietitians, we looked by patient. Physicians reported they were satisfied or very satisfied with 90% of their patients, and for dietitians, it was the case for 81% of their patients. We saw that families needed support to get going, and if we could get families through session one, if we could get them through, enroll the clinic, get them to go home, click that link to register, and actually complete session one, that we could get them to stick with the program. Our families are very busy, they have a lot going on, and what we learned was it was really this transition point to getting engaged with the program, and that if we were able to support them in doing that, then they were able to get through the program. And it was really important learning from our quality improvement work, and information that we will take going forward into subsequent studies. In summary, we found that BIC Digital was feasible to integrate into clinical care. It demonstrated acceptability and high satisfaction with families and clinicians. We learned that we had improved nutritional outcomes in children with CF using everyday food, and we found that it offers an early approach to struggles with growth and nutrition and mealtime behavior problems in children with CF using everyday food rather than supplements to increase calories and weight gain. And the evidence is, supporting of a dissemination trial.
Lisa, this was fantastic. Thank you so much for sharing this data in such a warm and approachable way. And it's going to be hard to narrow questions down to just a few minutes. But there are a number from the group, and we're going to begin to think a little bit about that. One question is, how was the eligibility for the study determined?
So again, we tried to have our exclusion criteria be as minimal as possible as we were trying to learn about implementing this in care and pulling it out of our really, sort of research, sort of model and thinking about how do we use this in practice, and with the variety of participants who or patients who come to us. So basic eligibility criteria were really that children needed to have a BMI below percentile below the 50th percentile, or if it was above, to show a real need for, have some real behavioral issues around eating and a real need for increased calorie intake. Some basic things like families needed to have technology. Most all families did this on an app, so they had to have either sort of a phone or a tablet or a computer where they could access the device. This only was in English, so we needed families to be able to speak and read English at this point in time. So kids who were really sick with CF, this again was not really appropriate for them. So those were very basic criteria. Otherwise.
Okay. Yeah. And so then we have a couple of enthusiastic questions about dissemination. So there are questions about when it will be widely available to use in centers and whether the app is available.
So currently the app is only available to, our at our participating centers, to people who enrolled in the study, because we were, trying to understand it and develop it and build it. We are, this data is fresh off the presses. As I said, we ended the study early due to COVID. So we've just, analyzed this data, and we're currently working with the Success with Therapies Research Consortium and the CF Foundation to think about next steps. And our next steps will be, how do we start to make this accessible and, continue to evaluate it as we do. So we are thinking about that currently, and hope more to come on that soon.
And any
our goal.
consideration for adapting it to the adult population, or are there similar programs available for adults?
There's not similar programs that I am currently aware of. This particular program is very behavioral. It's a sort of psychoeducation program that's very behaviorally based, really focused on how parents, sort of set up meal times and their behaviors at meal times and how they encourage and motivate children to eat. So this particular program would not be appropriate for the adult population, but certainly some of the basic core ideas of how do people learn to help themselves, learn to increase their calorie intake, and do that in a very sort of systematic and sequential way would be some ideas. But right now this is really designed for kids.
Got it. And so it sounds like there was collaboration on the team between the provider, the nutritionist, and maybe the social worker as well in terms of the behavioral aspects.
Yeah, for sure. We worked very closely with the, physicians, nurse practitioners, the dietitians, and then primarily psychologists were involved in this at the clinical sites. And each clinical site is different in terms of people's roles. So, and each family, has different relationships within the care team. So the clinical site would determine, who was most involved with the family and which players, sort of collaborated with families. But it was very collaborative, and that's the platform with the real-time data allowed that to happen, and allowed families to work with their clinicians both at clinic, but also between visits. And, so it wasn't that a family was going 3 months without being able to easily share with their team what was going on, or the team be able to give them feedback. So
we have time for one more question, and there are many questions coming in. So I guess I'll ask one, and then there may be a little time at the very end of the session. Was the program on the parents' phone or the kids' phone, and which was more effective?
Yeah, no, it was on the parents' phone. The parents, this was really designed for parents, again, given sort of the age range we were looking at, 3 to 10 years, really kind of thinking about from the nutrition side, really structured nutrition education around how do we get increased calories in the food without increasing the volume of food that we're expecting kids to eat. So how do we really boost that? And then from a behavioral parent training, really those behavioral parent training skills around how do we motivate kids to eat, and how do we, utilize parental attention to increase positive eating behaviors, and to, decrease those typical preschooler, school age behaviors of, picky eating and not wanting to eat, etc. So really designed for parents to implement with their kids.
So a family intervention.
Yes, yeah.
Well, Lisa, thank you so much. And audience, I see your questions about impact of Trikafta and technology barriers, and I hope that we'll have a chance to address those maybe at the end or perhaps after in another way. But Lisa, sign of a good abstract. You got the crowd thinking.
Awesome.
Thanks
Thank
so
you.
much. So next, I'm excited to introduce Dr. Sonia Graziano, who is a clinical psychologist and psychotherapist. She's a research fellow at the Bambino, oh no, Dr. Graziano, I didn't clarify how to say your center, Bambino Gesù Children's Hospital in Rome. See, I should have done study abroad, right? Fibrosis. She's a member of the ECFS Mental Health Research Working Group, and recently she became a member of the Cystic Fibrosis Foundation's Mental Health Advisory Committee. The abstract she'll be sharing, which is so timely for our meeting this year, is the psychological interventions for depression and anxiety during the COVID pandemic, effects of a telehealth intervention for individuals with CF and parent caregivers. Dr. Graziano, thank you so much and welcome.
Thank you and welcome everybody. I will present the results of a telehealth psychological support intervention for individuals with CF and parent caregivers during the COVID crisis. This intervention was developed and implemented with my colleagues at the Bambino Gesù Children's Hospital in Rome the week after we had a complete lockdown in Italy with the consultation of Alexandra Quitter as a senior scientist. Our lockdown in Italy was very restrictive, allowing only one person per family to go shopping at a time. However, no one was allowed to take a walk or visit an outdoor park. This lockdown began in March 2020, at least at about 2 months. The primary goal of the intervention was to improve symptoms of depression and anxiety and increase coping skills during this highly stressful period. There are no conflicts of interest to disclose related to this presentation. COVID-19 emerged in China, leading to significant morbidity and mortality across the world. In China, elevated depression and anxiety were reported in more than 1,200 people. Adolescents in China reported very high levels of depression, 43%, and anxiety, 37.4%, according to scores on the PHQ-9 and GAD-7. As the pandemic spread through Italy and Europe, new mental health concerns were raised about people with CF and their parents who were already at increased risk for depression and anxiety. As shown in a recent study, I published screening over 300 people at my center. This led to development of a telehealth psychological support intervention to help adolescents, young adults with CF, and caregivers cope with the stress and emotional challenges of the COVID lockdown. All participants completed 4 Zoom sessions, 30 to 40 minutes. Each session were conducted by a psychologist on the CF team every 1 to 2 weeks. A letter inviting participation in the intervention was sent by the CF Parent Association 1 week after the lockdown. The intervention was also shared through social media channels such as Facebook and Instagram. A dedicated phone number was used to accept requests of participation. The study was a within subject pre-post design. All individuals completed electronically measured at both time points, PHQ-8 for depression and GAD-7 for anxiety. Because of safety concerns, the PHQ-8 was used because it doesn't ask about suicidal ideation. Individuals provided a stress rating on a 10-point Likert scale at the beginning of each session. Feasibility and satisfaction with the intervention were rated on a 4-point Likert scale. Example of question included how practical, easy was to participate in this program? Did you find it helpful to participate in this program? The intervention focused on self-care, such as relaxation, coping skills, such as cognitive reframing, and was specifically tailored to address the individual emotional challenges. In the first session, individuals were asked to describe their stressful experience with the COVID pandemic and identify stressful coping skills and strategy on their own resilience skills and protective factors, for example, eliciting family support, reducing time watching the news. Initially, there was a lot of fear surrounding the pandemic, and people with CF and caregiver were engaging in a lot of catastrophic thinking. Therapists encourage a focus on the present moment, emphasize how well prepared they were to deal with the infection, given their own experience with the infection control. We built a toolkit of cognitive behavioral skill that we could use flexible in this session. The CBT skills included cognitive reframing, which facilitate more positive thoughts, promoting self-efficacy, increasing positive emotion, and tips for maintaining such as psychological and physical health during the lockdown. We reinforced the importance of maintaining normal routines for both patient and parent, which included getting up and dressed, performing the CF treatment, getting good sleep, and identify activity that increase positive moods. For example, reading a book, cooking or baking a favorite dish, listening to music, One exercise, Catching Joy, asks them to identify 3 moments of joy each day and record these on a worksheet on WhatsApp. These joyful moments were then discussed in the next session. Limiting exposure to the news about COVID-19 on TV, using technology to connect with family and friends to reduce social isolation, and practicing relaxation techniques were recommended. The sample consisted of 16 adolescents, young adults, and 14 parents. A high percentage of participants in both groups scored in a clinical elevated range on depression and anxiety. For patients in blue, depression and anxiety was 71% on both. For parents in yellow, depression was 57% and anxiety 79%. Moderate to severe scores were reported by 40% of patients for depression and 20% for anxiety. Similarly, 30% of parents reported moderate to severe depressive symptoms and 20% for anxiety. Results of this brief intervention demonstrated statistically significant reduction in stress for people with CF from 7.1 at pre-test, dropping to 4.9 at the post-test. For parents, average stress rating were 7.8 at the pre-test, dropping to 5.7 at post-testing, also highly statistically significant. Statistically significant reduction in depression were found for patients from 8 at pre-test to 4.7 at post-test. Symptoms of anxiety decreased but were not statistically significant. Similar results emerged for parents. Statistically significant reduction were found for depression, 7.4 at pre-test to 5.1 at post-test. However, this decrease in anxiety were not statistically significant. Feasibility and satisfaction rating were positive for both patient and parents. Feasibility was 3.3 for the question, how practical, easy was to participate in this program, and 3.2 for the question, do you think the project should continue? Satisfaction was 2.9 for the question, did you find it helpful for you to participate in this program? And 2.8 for the question, how satisfied were you with this program? These results suggested that intervention was both feasible and helpful. In this slide, you can read some comments from participants based on the question, what did you like about the intervention? These slides summarize our main point and conclusion. During the COVID crisis, rates of depression and anxiety were highly elevated in patients with CF and parents, with a large proportion in the moderate to severe range. Results showed that this brief intervention significantly reduced rating of stress and symptoms of depression in patients and parents. Anxiety decreased, but was not statistically significant. It is possible that anxiety did not decrease as much because people were still living each day with the crisis. Triggers for anxiety were ubiquitous, for example, the news, mortality rates, economic recession, and extreme social isolation in Italy may also have raised the level of anxiety. We demonstrated that this intervention can be used in a crisis situation with simple technology. At the end of the intervention, both patient and parents wanted to keep having this session. Note that this session is not a substitute for a more comprehensive intervention or for ongoing psychological support from a mental health expert on the CF team. Our results show that this intervention was effective. It was rated as feasible and satisfactory by these consumers. Of course, a future randomized control trial is needed of this intervention. It is being planned to test its efficacy. Thank you very much, and I want to thank you all my group.
Oh, Dr. Graziano, that was a beautifully done, just elegant presentation describing the intervention, and so nice to have the effects measured a little bit as well. A few follow-up questions. I mean, one is, if you noticed any skills that were particularly helpful for parents and kids?
Yes. This is a very good question. Most effective skills were based on feedback from participants. Based on feedback of participants, were, for example, the exercise catching joy, exercise where we ask them to find 3 moments of joy during the day and record this moment in a worksheet on WhatsApp. This was very good because they were able to focus on something very small and don't think too much about the catastrophic thinking. And another very important skills I found was to help them to maintain their routines. For example, getting up and dressed, don't stay up all night and watch a Netflix movie and focused on their resilience and their coping skills.
I love how practical and easy to apply the skills you describe are. That's one of the things that makes it so elegant. One of the questions from the group is whether the satisfaction data was skewed by a few people or if you had limited variability in this measure.
Do you mean in terms of if all of them completed the, yes, all of them completed the satisfaction and the feasibility questionnaire. So we match them, parents and patient, because our sample is not so big, but we are planning to continue our study. And of course, if we are planning, for example, to do a randomized control trial to better prove our results and confirm our results and the efficacy of our results, because up to now we have some measure about feasibility and satisfaction, but of course we have to better understand the efficacy of the intervention.
Were the interventions done in a group format or one-on-one?
Was one-on-one.
And have you continued any of the sessions beyond May?
No, we didn't, because the intervention was planned to help people during the lockdown situation, because most of them were not able to come to the hospital as always, and also some of the team, the people of the team were not able to attend the hospital. But we did a follow-up of this patient and parent caregivers after the intervention. And unfortunately, probably we will start again the intervention because we are very close to another lockdown, because a lot of restrictions are coming up during these days. So this was a pilot study, but I think we can use, or maybe we must use it again soon.
Right. And as with Lisa's presentation, you're getting so many enthusiastic questions from the group. We're not going to get to them all. We have time for one, maybe two more. And one of the questions that's been repeated a few times is to ask you to talk a little bit more about how there was a statistically significant reduction in depression, but not anxiety. And if you can talk a little bit about any potential factors besides generalized COVID factors that might explain this finding, or if that's really the basis for the finding.
Yes. I like this question because we thought about why we had these degrees of depression, but not anxiety. Of course, we had a lot of anxiety linked with COVID, but I think that in terms of the ill, the anxiety was very high, because at the beginning they were very, very afraid about the fact that the COVID can be a risk factor for CF patients, and not just in general for the recession and for other specific things linked with COVID. But of course, it's also true that the sample is not so big, so we can think about and make some hypotheses. But of course, we have to prove the hypothesis increasing the sample size.
Right, right. Well, thank you so much for the insightful answer to that last question, which was a tough one. I apologize for that. And for your such a graceful presentation. I'm so grateful to you. And we'll now move on to the third abstract. And it's my honor to introduce Dr. Martin Wildman, who's an adult pulmonologist from the UK, who will take us through a 600 patient randomized control trial, looking at a self-care intervention. I believe he's going to signpost some of the differences, excuse me, between a double-blind placebo-controlled drug trial and a randomized but non-blinded behavior change, which is a great topic that could be like a 3-hour lecture, Dr. Wildman. The title of his abstract is "The Effectiveness of a Self-Management Intervention to Support Treatment Adherence in Adults with CF and RCT." Dr. Wildman.
Oh. Hi there, I'm just trying to share my screen.
Well, and while Dr. Wildman is doing that, I should comment that all of us people in the US who are whining that the meeting goes late, we should keep in mind that Dr. Wildman and Dr. Graziano are presenting at like midnight. So.
I'm really sorry that I'm taking a moment to share my screen. I'm not sure why that's not working. Here we go. Do you now see my screen? Yes, great. Okay. Can you hear me as well? Good. Thank you very much for inviting me, and I'm sorry that I have had some technical difficulties there. So yeah, I'm going to talk about this randomized controlled trial to improve adherence to inhaled therapies using nebulizers. These are my disclosures. And when it comes to thinking about adherence to nebulizers, there are some literature out there now using date and time stamp data to give us some kind of idea about how much treatment that people actually take. And when we go back to 2008, a study in Leeds run by Tracy Daniels, who's a physio there, demonstrated that unadjusted nebulizer adherence using iNebs, which is a chipped UK nebulizer made by Philips, the adherence was 36%. But that was in a sample where 105 nebulizers were given out, but only 78 ever came back to the clinic to be downloaded. So this was an opportunity sample. In Sheffield, we repeated that sample, that study back in 2013, and made sure that we got all the chip nebulizers back. And there we saw a normative adherence, so that's adjusting the amount of treatment people take for their clinical characteristics of 31%. And we've subsequently repeated that that estimate of adherence across a sample in 200 patients in Southampton, Nottingham, and Sheffield in the UK, and found the adherence in that sample was 32%. So it looks like this is what untreated adherence for nebulized therapies in adults is, about 30%. It's important to remember as we move into the modulator era, that we also know, this is some work from Cincinnati, that adherence to modulators is also not miraculous. And a study from Cincinnati back in 2013 suggested that ivacaftor adherence may only be 61%. So some of you will have heard me talk before, and I often show this cat. So here's a cat playing whack-a-mole. And it just reminds us that when it comes to behavior change, one of our big destinations with the program that I've been working on is to try and move the behavior that we're trying to sustain beyond whack-a-mole. So the interventions are attempting to move behaviors into routinization and habit. So that's beyond the whack-a-mole that this cat is exhibiting, which is paying attention to a behavior in order to sustain that behavior, and that requires willpower. So we want to move behaviors beyond willpower to automaticity. And here's our conceptual framework of behavior change. And what we did in this study was we gave the intervention group e-track data logging nebulizers, which are just like the eFlows, which I think you're probably familiar with in Europe and the United States. But these are actually chip ones that take data, time and date stamp, send it to the cloud, and then back to the patients on their mobile phones and the clinical teams. And what the interventionists did was they attempted to address patients' motivation in terms of their necessity concerns for in-health therapy, and then get them to actually start to repeat that behavior so that they would encounter barriers. We would then use implementation plans to help them to move towards those barriers, and also coping plans to help them to deal with that. And then the aim was to repeat the behavior in the context of a fixed cue in order to create automaticity or habit formation. And the comparator was usual care, so they had a chip nebulizer, but they didn't get any data back from it. So the trial involved 600 participants. Eligibility were people 16 and above who were able to use the nebulizer, and the exclusions were people who were post-transplant or were using dry powders. And here are the demographics, roughly equal male and females. We randomized by stratifying for previous IV days, and also stratified at the level of center where the block sizes were about 30 patients. So there was some imbalance in the baseline characteristics, and in fact the intervention group were slightly older, but surprisingly had slightly better lung function and slightly higher adherence. And what I want to do now is show you the curve of the adherence response over time. So this curve shows the normative adherence over time, so that's adjusted for patient characteristics over the 12 months of the trial. And I want to pay attention to this curve in a little bit more detail to help us understand the impact of Hawthorne effect, and also the effect of randomization on the day of allocation. So the top line in this curve is the intervention group, and the bottom line is usual care over a period of 12 months. But let's just go to the beginning of this curve, which helps us to understand one of the problems of doing non-blinded behavior change trials. So let's just look at this part of the trial. And what you can see here at the very beginning is the intervention group had higher adherence at baseline, and the control group was slightly lower. But the adherence was measured over the first 2 weeks of the trial. And on the day of allocation, the patients were randomization was via a computer system, so it was a blinded randomization in terms of the interventionist, but the patient was told on the day. And some of that abrupt fall in adherence that you can see in the first 3 weeks of this study was partly related to people knowing, though they wanted the intervention, they'd actually got the control. But you can also see that the intervention group also fall, and fall fairly rapidly, which is the effect of the Hawthorne effect, first being monitored. But what you can see is, but by the time we get to week 3, which is when we first delivered the intervention to patients, the intervention groups start to change, and they start to change really quite markedly. And when you look at the control group over time, they continue to fall. And by the time we get to 50 weeks, the control group have actually fallen back to what we would see as their normal baseline, which was in the region of, in this case, it was about 35%. But the intervention group have improved and reached a level of adherence of about 50%. And so what we see is that by the time we get to that 50 weeks, The adjusted mean difference, taking into account the Hawthorne effect at the beginning, was 9.5%. The absolute difference was 18%. So that's what we saw in terms of adherence. These are our other outcomes. The primary outcome upon which we powered the study was exacerbations. And you can see that there was a difference, but non-significant, between intervention and control in terms of exacerbations. The FEV1, there was a non-significant difference between intervention and control. Body mass index was slightly increased. Habit strength was significantly increased. CFQR treatment burden significantly fell. In terms of beliefs about medication, concerns about medication fell, necessity for medication increased. So what we see here is that one of the other aspects of this study was that we over-recruited high adherers. So 30% of our participants were on the ceiling at the start of the study. One of the reasons for that was we recruited very quickly because we had to, because that was our funding. But that did mean that we tended to recruit people who were easy to reach. And there was also the baseline imbalance that I've already mentioned. I just want to mention something about the ceiling effect. So in that group of patients who had adherence greater than 76% at baseline, we did significantly increase the adherence by about 6%. But in the group with 26 to 50% adherence at study entry, the actual increase in adherence was more like 18%. So to make these studies more effective and efficient, it's probably a good idea not to recruit the highest adherers. So it's important to know your adherence measures before you actually start. So in terms of, I'm going to jump over these two, and I just want to go to the summary because I know I'm at 10 minutes. So what we found in this study was that we did see a significant difference in normative adherence, maintained in the trial to 52 weeks, but we had follow-up for those patients who entered the study early and their adherence continued out to 80 weeks, for those who were in the study for the longest. Habit strength was increased. I think that's really important, and that's probably the mechanism of dropping the CFQR domain of burden, because automaticity, once people move beyond whack-a-mole, things become automatic and the effort drops. There's an increase in necessity, there was a fall in concerns, and there was that decrease in perceived treatment burden. The increase in BMI was small. I think that lung function may take a little while for it to pick up, and also lung function is difficult to measure with fidelity. It's not quite as easy to measure with fidelity as BMI. So we found it encouraging that BMI had increased. Most importantly, there was no difference in anxiety and depression. So by feeding back data to these people and supporting their adherence, the good news was that actually the relationship shielded them from the challenge, I think, of working on their adherence, and there was no difference in anxiety and depression. Possibly somewhat disappointingly, there was no difference in exacerbations or lung function. That might be something that we might discuss in the questions. Thank you. And just to not to forget all the people who did all the work, and here they all are on this slide here.
Oh, Dr. Wildman, that's a fantastic presentation, in part because you described the project's design so well. It was really interesting to see how that played out, and really encouraging in terms of your results. Lots of questions from attendees. The first set of which is more about the modality of the intervention. So how many sessions were delivered by the trained interventionist and over what time period?
This was a tailored intervention. And so the number of interventions would to a certain extent be determined by what the patients wanted and needed. The average amount, the median amount of time that in terms of intervention was delivered was about 160 minutes per interventionist over 12 months. And the shape of the intervention would depend patient by patient, depending on how they responded. And so with the first intervention, it was an orientation, and some of the interventions was delivered. And then the number of interventions thereafter would depend on the way that the patient responded in terms of their adherence and what they wanted. Hope that makes sense.
Yeah, interesting. So other questions are about the differentiation between high adherers and low adherers, and whether there were factors that could predict subgroup membership. Do you have any comments or thoughts on that?
Well, one of the very important determinants of people's adherence was age. I mean, I think that's something that is well described in the literature, and so the age was an important determinant. Other than that, there wasn't that much within the data set to predict. In a sense, we didn't need to predict because we measured it and we knew. So once you've got date, once you've got date and time stamped data on how much treatment people take, the need for prediction is less important because you simply measure it, and then once you've measured it, that's what it is, and you respond to it. Got
it. Probably just time for one or two more questions. The intervention focused on enhancing knowledge. Were potential modifiers of outcomes also measured as mechanisms of behavioral change? Things like knowledge about medication use, motivation or readiness, kind of softer outcomes versus the clinical outcomes you were looking at as well?
So the outcomes we measured are the outcomes that we reported primarily. So when it came to the knowledge was the knowledge and education that was available was within CF Health Hub, and it tended to address the concerns that the patients had. So the necessity on concerns, they were kind of the outcomes of the interventions to alter knowledge. So the aim of the knowledge interventions was to increase people's necessity for treatment and decrease their concerns about treatment. So some of that education might have been around the mechanism of how things worked, but there was also education about things that were really important to patients. For example, how do I make my nebulizer go fast? How do I actually use my nebulizer when I go on holiday? How do I use it when I travel? So the actual information that was given to patients around those things was very much what our qualitative work earlier in the development of the intervention had actually told us was important. One of the other things that I think was quite interesting and useful was that we worked with a group in Oxford to produce a series of videos, and those videos were people with CF who we had measured and known to be pretty good at adherence but not perfect. And what we asked them to do was talk to the interviewer to explain, as if they were talking to their younger self or a younger sibling or a friend, what were their secrets that enabled them to win the battle of adherence. So that was so much better than somebody like me with grey hair giving them advice. This was, essentially this was vicarious efficacy. So this was looking at people like me who've solved the challenge that I want to solve. So actually all the interventions were, one of the things that we use the COM-B model of behavior change, which has got a series of intervention domains which map into capability, opportunity, and motivation. So the vicarious self-efficacy, of course, was one of those domains which we were attempting to target by the intervention components, which we haven't particularly managed yet, which we haven't mentioned in this talk.
Nice. Well, thank you so much, Martin, and the rest of the speakers. I want to give a huge shout out to Laura Dingra, who was the moderator in the background, fielding all of your amazing questions and pushing them out to me. And she's a clinical psychologist, a clinical health psychologist at Einstein Montefiore in New York City. Thanks so much to Lisa Opipari, Sonia Graziano, Martin Wildman, and the CF Foundation. This session could have been 4 hours. I appreciate your brevity and clarity and insight in this tight amount of time, and thanks so much.